Welcome back to MedOnePager. My name is Benjamin, and today I'm going to be talking about chronic kidney disease. This is a condition that is going to be very common both on the wards and as well as in your examinations. So, chronic kidney disease is going to be defined as an abnormality of kidney structure or function present for more than 3 months with implications on health, or it is a decreased glomerular filtration rate of less than 60 mL per minute per 1.73 meters squared for at least 3 months. So the normal glomerular filtration rate, or the amount of fluid that is filtered by the kidneys glomerulus per minute, is going to be approximately around 120 mL per minute in a well-developed kidney, in an adult kidney. And in persons having chronic kidney disease, we're going to have that glomerular filtration rate start to go down and go down. But it's important to also understand that normally as humans age, as you reach around the third decade or the fourth decade of life, that is where we have the peak glomerular filtration rate, and that is about 120 mL per minute. But starting from there, it starts to reduce by 1 ml per minute and every year. And approximately at around 70 years, the glomerular filtration rate is going to be at 70 mL per minute. So what's happening in chronic kidney disease is that we are having these insults on the kidney for a long time, or they could be ongoing. And what they're going to do is that they're going to cause death of some of the nephrons of the kidney. So someone is, again, a well-developed kidney is going to be having around 1 million nephrons, and each of these nephrons that is destroyed is not regenerated. So a person is going to have an etiology, or is going to have a condition that is going to destroy some of these nephrons. And as the nephrons are destroyed, the other nephrons are going to adapt. They're going to work harder to meet the demands of the body to try to keep the glomerular filtration rate up there. So what is going to happen is that these hypertrophied nephrons are going to be more prone to injury, or are going to be destroyed so more easily. So as this continues, we are going to have an increased pressure, or what we call an increased glomerular pressure. And that increased glomerular pressure is going to put a lot of pressure on the walls of the capillaries found in the glomerulus. And this is going to lead to injury of those capillaries, what we call the glomerulosclerosis. And as that continues, the pressure keeps on building. We're going to end up with tubular interstitial fibrosis. We're going to have vascular rarefaction. And that is what is going to actually lead to the progressive CKD, because more and more nephrons are going to be lost, and we shall not be able to actually compensate. And it is not until someone has lost about 50% of the nephrons that they would start to present with symptoms, or that the creatinine will start to rise. And therefore, it is very important that people who are at risk of having chronic kidney disease are screened earlier, and interventions are done to see that we do not have progression to end-stage renal disease. And whenever someone requires renal replacement therapies, or what we call dialysis, in the form of dialysis or in the form of a transplant, we call that end-stage renal disease. So we have some of the causes of chronic kidney disease, and while the common causes are going to be diabetes mellitus, which is the leading cause, we are going to have hypertension, we are going to have glomerulonephritis, HIV-associated nephropathy, polycystic kidney disease, obstructive uropathy, and chronic pyelonephritis. And obstructive uropathy is going to be among the common or the leading causes in children, glomerulonephritis in the blacks, and diabetes mellitus is going to be actually common worldwide. So the clinical features are always going to come in very late. Most of the time, someone is going to keep on compensating the kidney. The other nephrons will always compensate and try to work hard for the ones that are lost. So let alone, that's when we shall have features of fatigue, pruritus, which is itching of the skin. And this is going to be due to the Uraemia, We shall have anorexia. We shall have nocturia, which is increased urination during the night, and we shall have edema and cramps. Then we shall have signs like hypertension. We can have pallor. We can have edema. We can have uremic fever, which is a bad smell of Uraemia. We can have the pericardial rub, and this is due to a pericarditis, and also it's going to be caused by the Uraemia. So we have features that are going to come from this chronic kidney disease, and they're going to be actually affecting very, very many systems. So when you look at the urinary system, you'll see things like polyuria, you'll see oliguria, anuria, depending on depending on what is going on. So most of the times when you have like tubular interstitial pathology, remember that renal tubules are important in concentrating urine. They absorb most of that water back from the glomerular filtrate. And if you have their destruction, the tubular interstitial fibrosis and other kind of injuries or sclerosis, we're going to have a polyuria because the kidney cannot concentrate that urine. We can have oliguria, we can have anuria, and these are coming from failure to actually, that different problems are coming in. Then we shall have the cardiac system where we shall have hypertension, we can have heart failure, we can have pericarditis. So most times when we have a chronic kidney disease, there's activation of the RAS system. And the RAS system is going to cause absorption of water and sodium, as well as vasoconstriction from the effects of the angiotensin. And whenever you have vasoconstriction, the heart is going to work hard and we have hypertrophy. So it's very common that people with chronic kidney disease are going to end up with hypertension, which hypertension is going to cause hypertrophy of the heart muscles, and this is going to lead to heart failure. Then we can have pericarditis, which comes from the uric acid, the Uraemia, when it extravasates into the pericardial membrane. It's going to cause a pericarditis, and that will cause that. Then we have the GI system where we have anorexia, nausea, and vomiting, and this is also coming from the urea. We have the skin where we have pruritus, we have pallor, then we have anemia, and anemia is going to be caused by very many things. It could be caused by the iron deficiency, it's going to be caused by lack of erythropoietin, it could be the increased destruction of red blood cells because of the urea, it could be increased destruction again of the red blood cells because of the dialysis. So many things are going to contribute to the formation, to the anemia in these patients. We shall have things like decreased libido, amenorrhea, infertility. We shall have neurological symptoms like altered consciousness. We shall have seizures and coma, decreased ability to concentrate, dialysis, encephalopathy. And we also, altogether, these things may be referred to as uremic encephalopathy. Then we have the pulmonary system where we have crackles, and this could come as a result of the increased water retention to pulmonary edema. We can have uremic pneumonitis, we can have Kussmaul type respirations, and then we can have tachypnea. And we can have also the electrolyte imbalances like hyperkalemia, hyponatremia, hypocalcemia, hyperphosphatemia, and metabolic acidosis. And this hypocalcemia and hyperphosphatemia are going to play a very, very big role in the occurrence or in the pathophysiology of renal osteodystrophy. So when you go to Uraemia, we're going to have some of the signs of Uraemia, and these are going to include the general signs: skin, neurological and cardiovascular, hematological, and metabolic. And these are important because they could easily show up on your exams, and you're asked to explain this or give some of the signs and symptoms of Uraemia. So one, we're going to begin with nausea, anorexia, malaise, uremic fever, which is the smell, metallic taste, and hypothermia. On the skin, we can have a uremic frost where someone looks like they have a whitish kind of salt on their skin. You can have a pruritus, calciphylaxis. Then we go to neurology. We can have encephalopathy, which I talk about, the uremic encephalopathy, which will be having things like decreased memory and attention, seizures, neuropathy, impaired sleep, restless leg syndrome. We can have cardiovascular effects like pericarditis, atherosclerosis, hypertension, congestive heart failure, and cardiomyopathy, and particularly left ventricular hypertrophy. We can have hematologic conditions like anemia, and we can also have bleeding. Then we have metabolic, like increased potassium, increased phosphate ions, acidosis, decreased calcium, secondary hyperparathyroidism, and osteodystrophy. The staging or the classification is going to be as follows. We are going to consider the amount of albumin in the urine as well as the glomerular filtration rate. So when someone has a glomerular filtration rate greater than 90, we are going to think maybe that is normal or it might be high. Then we can have a moderately decreased, which is below 60, which is below 90, and that is 89 to 60. Then mildly to moderately decreased, which is G3A, that is 45 to 59. You have the G3B, which is moderately to severely decreased, and that is a glomerular filtration rate around 30 to 44. Then G4, which is severely decreased, 15 to 29, and below 15, we say that is the G5, and that is mostly the one we refer to as end-stage renal disease. Then the other side, you have the albuminuria. So when we have less than 30 milligrams, but less than 30 milligrams per gram, or less than 3 milligrams per millimole, that is the normal or mildly increased. Then the moderately increased, so is 30 to 300 milligrams per gram, or 3 to 30, which is in milligrams per millimole. And severely increased will be greater than 13 milligrams per millimole or greater than 300 milligrams per gram. So when you look at this, when we are grading our patient, we are going to grade them using both the albumin in urine as well as the glomerular filtration rate. So, for example, if our patient has a glomerular filtration rate of 45 and in their urine they have albuminuria of around 300 milligrams per gram, we are going to give them class or a stage of G3A H2. When we go to the general principles of management, we are going to try and slow the progression of the disease as well as reduce the complications. And we are going to identify and treat the reversible factors. So when we do the investigations, we have the serum creatinine, we can do electrolytes, we can do the calcium, phosphate, parathyroid hormone, hemoglobin, and the bicarbonate. Then on urine, we want to do the albumin creatinine ratio, and this is going to be a spot test in the morning. We want to do a urinalysis for hematuria, proteinuria, on imaging. We can do the renal ultrasound, and in chronic kidney disease, most of the times you're going to see a small echogenic kidneys, except like in conditions like diabetes, polycystic kidney disease, and amyloidosis, the kidneys may actually be large. Then we can do a biopsy if we want to come up with the etiology of the disease. And then we can do other labs that help act as markers for the progression. For example, albuminuria. So we know as the albumin in urine worsens or increases, we are tending to have a more progression of the disease. And if we have a rapid decline in the GFR, it would also not be a good thing. Then resistant hypertension is another marker of progression of the disease, because it means we are having more blood water retention and RAS activity, and anemia, hyperphosphatemia, all those are markers of progression of the disease. So when we try and look at the complications of chronic kidney disease, we can start with hypertension and cardiovascular disease. So what happens is that we are having sodium and water retention, which is activating the RAS, causing the vasoconstriction, and this is going to lead to fibrosis, anterior stiffness, and this is going to increase the systemic resistance, and this is going to cause hypertrophy of the left ventricle. So in the management of this condition, giving S inhibitors or angiotensin receptor blockers is going to be very, very, very important to counteract these deleterious effects of the RAS system. So the ABs or the S inhibitors are going to be the first line for this condition. Then of course we want to consider other things like the beta blockers, calcium channel blockers if necessary. We can do salt restriction, SGLT2 inhibitors, as well as manage our lifestyle. Then when we look at the proteinuria is going to come from glomerular hyperfiltration and increased intraglomerular pressure that damages the podocytes, which normally prevent the extravasation of proteins. So this time we haven't have the proteins adhering, and it's important that we use ACE inhibitors, as these ones will help reduce on the proteinuria, or they will help reduce the amount of protein in this urine. Then we have some new drugs like the non-steroidal mineralocorticoid receptor antagonists like finerenone have also been used. We can do dietary restriction of sodium. SGLT2 inhibitors have also been used. Then anemia. Anemia is going to come from various things, and it's important that before you consider giving erythropoietin, which is the hormone produced by the kidneys that help signal the bone marrow to produce cells, it's important that you first try and solve any other things that could be causing the loss of the red blood cells. For example, if we are having an iron deficiency, you need to first correct that. So we want to make sure that we correct the iron until the stores ferritin is high enough, and then we can consider giving erythropoietin. And we want to target an HB of around 10 to 11.5, and we never want to go above an HB of 13 grams per deciliter. Then we look at chronic kidney disease, mineral-borne disease, which is also called renal sheath dystrophy. And this one is mostly going to come, or most of the time is going to come from the phosphate retention, because the kidney is responsible for excreting phosphate, and when it don't excrete this phosphate, we're going to have a lot of phosphate in blood, and phosphate will react with calcium, come together and form calcium phosphate. So the levels of calcium are going to fall, and we shall have a hypocalcemia. So this hypocalcemia is going to lead to signaling of the parathyroid hormone to produce a lot of parathyroid gland to produce a lot of parathyroid hormone, and we shall have a secondary hyperparathyroidism. The increased phosphate themselves are very capable of stimulating this. The other thing is that the kidney is responsible for activation of vitamin D, and in this case, it's not functioning very well. So vitamin D levels go down. They're going to lead to a decreased absorption of calcium from the GIT, and when this happens, we're going to have a low calcium, and this is going to lead to the secondary hyperparathyroidism. And when all this happens, it's going to lead to decreased calcium absorption, as well as it's going to lead to increased bone turnover or osteoclastic activity. This in the end is going to cause weak bones that easily break, and that is what we call the renal sheath dystrophy. So the management is that we can give dietary phosphate restriction, try to give them phosphate binders. These include like sevelamer, calcium carbonate, and these ones are going to bind to the phosphate and reduce its absorption in the blood. Then we have the vitamin D analogs like calcitriol, paracalcitriol, calcium mimetic. Then we can do a parathyroidectomy if it is refractory. Then we have metabolic acidosis, and this is due to the decreased excretion of ammonium ions and buffering of the hydrogen ions, and this is going to cause a chronic acidosis, and this is going to be managed by oral sodium bicarbonate. And if this is refractory, because we want to have a target serum bicarbonate of greater than 22 millimoles per liter, so if we are failing to do this, you may actually need dialysis. Then we have hyperkalemia, and this one is due to the decreased distal excretion of potassium, and this is because mainly we have a low nephron and also the RAS blockade, which is hypoaldosteronism. So the RAS system is being blocked, calcium is going to stay high in the blood. So we can do the calcium restriction, we can use diuretics like root diuretics, potassium binders can also help. Then in emergency, when we have an increased potassium, we may consider using things like calcium gluconate, insulin. And if this cannot help, we have to consider dialysis. And we have to know that even the ACE inhibitors as well as the ARBs are very well capable of worsening hyperkalemia. So we need to monitor this very well, very, very, very closely. Then we have dyslipidemia. And this one is due to maybe insulin resistance, lipoprotein, lipase, decreased lipoprotein and lipase. And we have increased triglycerides as well as the LDL. And this one we shall try to use statins. Uremic syndrome is going to be caused by accumulation of uremic toxins. This is going to cause encephalopathy, pericarditis, neuropathy, and platelet dysfunction. So Uraemia is one of the indications for dialysis. And then we shall do supportive antiplatelet precautions to avoid maybe the thrombus formation. Then we can give seizure treatment for those who develop uremic encephalopathy. And then urgent dialysis when we have pericarditis. Then we have infections. So this is because of dysfunction of the immunity cells, because maybe we are losing the proteins and everything. So the immunity is going to go down, and you only want to do vaccination for those infections that we can control, like hepatitis B virus, pneumococcal, influenza, and COVID-19. Then we can have malnutrition, which is protein energy wasting. And this is because of the inflammation, the anorexia, metabolic acidosis, and dialysis related losses. So I want to ensure they are having an adequate protein diet of around 0.8 grams per kg if they're on dialysis, and then we can give the nutritional supplements. Then we have the neurological complications. Those are also due to the uremic toxins, like we talked about, and this includes encephalopathy, neuropathy, and electrolyte disturbances. And normally anything to do with Uraemia, dialysis may be important to correct that. And for the neuropathic pain, gabapentinoids may be used. So we have come to the end of this video. So if you find this video helpful, I would appreciate if you left a like or a comment, or you shared with a friend. See you next time.